Assalamu alaikum. My name is Hatem Saffan. I'm a professor of pediatric surgery. Our lecture is about some important causes of lower gastro-intestinal obstruction in children. First is anorectal malformation. In this lecture, our learning objectives are to cover anal anatomy, embryology of the imperforate anus, definition, incidence, classification, approach, prognosis. This photo shows important anatomical features of the anorectal region. Embryology of the imperforate anus. Between 4 to 6 weeks, the cloaca becomes the common depository for the developing urinary, genital and rectal systems. The cloaca is quite promptly divided into an anterior urogenital sinus and a posterior intestinal canal by the urorectal septum. Two lateral folds of cloacal tissue join the urorectal septum to complete the separation of the urinary and rectal tracts. The exact etiology of anorectal malformation is unknown. Its incidence is 1 in 4,500. About 60% male. Anorectal malformations represent a wide spectrum of defects. The terms low, intermediate, and high are not useful anymore in therapeutic or prognostic terms. It is now better to classify arm and each sex separately. Rectoperineal fistula is what traditionally was known as a low defect. The rectum is located within most of the sphincter mechanism. Only the lowest part of the rectum is anteriorly mislocated. Sometimes, the fistula does not open into the perineum but rather follows a subepithelial midline tract, opening somewhere along the midline perineal raphe, scrotum, or even at the base of the penis. This diagnosis is established by perineal inspection. No further investigations are required. Some cases of rectoperineal fistula. Imperforate anus with the rectourethral fistula is the most frequent defect in male patients. The fistula may be located at 1. The lower, bulbar, part of the urethra. Lower urethral fistulas are usually associated with good quality muscles, a well-developed sacrum, a prominent midline groove, and a prominent anal dimple. 1. The higher, prostatic, part of the urethra. Higher urethral fistulas are more frequently associated with poor quality muscles, an abnormally developed sacrum, a flat perineum. In this defect, the rectum opens into the bladder neck. The patient usually has a poor prognosis for bowel control because the levator muscles, the striated muscle complex, and the external sphincter frequently are poorly developed. The sacrum is often deformed and short. The perineum is often flat, which is evidence of poor muscle development. About 10% of males with anorectal atresia fall into this category. Interestingly, most patients with this unusual defect have a well-developed sacrum and good muscles, and have a good prognosis in terms of bowel function. The rectum usually terminates approximately 2 cm from the perineal skin. In this extremely unusual defect in male patients, the lumen of the rectum is totally or partially interrupted. The upper pouch is represented by a dilated rectum, whereas the lower portion is represented by a small anal canal that is in the normal location and is 1 to 2 cm deep. These two structures may be separated by a thin membrane or by dense fibrous tissue. The repair involves a primary anastomosis between the upper pouch and anal canal and is ideally approached posterior sagittally. Patients with this defect have all the necessary elements to be continent and have an excellent functional prognosis. Because they have a well-developed anal canal, they have normal sensation in the anorectum and have almost normal voluntary sphincters. From the therapeutic and prognostic viewpoint, this common defect is equivalent to the perineal fistula described in the male patient. The rectum is well positioned within the sphincter mechanism, except for its lower portion, which is anteriorly located. The rectum and vagina are well separated. Rectovestibular fistula is the most common defect in girls and has an excellent functional prognosis. The diagnosis is based on clinical examination. A meticulous inspection of the neonatal genitalia allows the clinician to observe a normal urethral meatus and a normal vagina, with a third hole in the vestibule, which is the rectovestibular fistula. This defect in female patients carries the same therapeutic and prognostic implications as described for male patients. This defect in female patients carries the same therapeutic and prognostic implications as described for male patients. This group of defects represents the extreme in the spectrum of complexity of female malformations. A cloaca is defined as a defect in which the rectum, vagina, and urinary tract meet and fuse, creating a single common channel. The diagnosis of persistent cloaca is a clinical one. This defect should be suspected in a female born with imperforate anus and small-looking genitalia. Careful separation of the labia discloses a single perineal orifice. 1. Sacrum and spine. Sacral deformities appear to be the most frequently associated defect. 1. Genitourinary defects. The frequency of associated genitourinary defects varies from 20% to 54%. 1. Anal atresia may occur as a part of the VACTERL group of anomalies. V. Vertebral body segmentation defect. A. Anal atresia. C. Cardiovascular, PDA, VSD. Tate brachioesophageal fistula. R. Unilateral renal agenesis. L. Limb anomaly, radial ray hypoplasia. So, very careful examination of the baby must be made to exclude these anomalies during the first 24 hours. The neonate should take nothing orally, receive intravenous fluids and antibiotics, and be evaluated for associated defects that may represent a threat to life. These include NGT to exclude esophageal atresia, echocardiogram to exclude cardiac malformations, esophageal atresia, radiograph of the lumbar spine and the sacrum, spinal ultrasonogram to evaluate for a tethered cord. Ultrasonography of the abdomen will evaluate for renal anomalies. Urine analysis, after 24 hours. Re-evaluate. If the neonate has signs of a perineal fistula, treatment is by doing an anaplasty. Without a protective colostomy, this can be performed during the first 48 hours of life. If there is no meconium on the perineum, we recommend obtaining a cross-table lateral radiograph with the patient in the prone position. If hair in the rectum is located below the coccyx, and the patient is in good condition with no significant associated defects, one may consider performing a posterior sagittal operation with or without a protective colostomy. Conversely, if the rectal gas does not extend beyond the coccyx, or the patient has meconium in the urine, an abnormal sacrum, or a flat bottom, a colostomy should be done. Then perform a posterior sagittal anorectoplasty 1 to 2 months later, provided the neonate is gaining weight appropriately. Pelvic colostomy. This diagram shows proper management of female anorectal malformations. Hirschsprung's disease. Hirschsprung's disease is the most common cause of lower intestinal obstruction in neonates. In this lecture, our learning objectives are to cover definition, pathophysiology, diagnosis, management. Hirschsprung's disease, a ganglionic megacoven, is a congenital anomaly caused by migratory failure of neural crest cells leading to abnormal innervations of the bowel. Its incidence is about 1/5,000 live birth newborn. 70 to 80% are boys. It is less common in blacks. The fundamental pathology in HD is the absence of ganglion cells in the submucosal and intermuscular nerve plexuses and is associated with an increase in the nerve fibers in the affected segment. That ganglionic segment usually involves the terminal intestine that is the rectum or rectosigmoid. The ganglionic segment may, however, include the entire large bowel and even small bowel. The colon proximal to the ganglionic segment, in an effort to overcome the partial obstruction, becomes distended and its wall markedly thickened because of muscle hypertrophy. The degree of hypertrophy and dilatation depends upon the duration and degree of obstruction and thus, indirectly to the age of the patient. HD is usually a solitary anomaly in a full-term, otherwise healthy infant. Associated anomalies do occur in nearly 20% of cases. urogenital system, 11%. Cardiovascular system, 6%. Gastrointestinal system, 6%, with 8% having various other malformations. Prematurity is reported in as many as 10% of those children with HD. Trisomy 21 occurs in approximately 5% of cases. 1. Failure to pass meconium in the first 24 hours of life. 98% of neonates pass meconium in the first 24 hours of age. Any newborn who fails to pass meconium in the first 24-48 hours of life should be evaluated for possible Hirschsprung's disease. 2. Neonatal intestinal obstruction and its symptoms include bilious vomiting, abdominal distension and refusal to feed. 3. Recurrent enterocolitis, mainly in the first 3 months of life. 4. Toxic megacoven, presenting with fever, abdominal distension, bile-stained vomitus, explosive diarrhea, dehydration, shock. 5. Spontaneous perforation occurs in 3%, especially if long-segment ganglionosis. 6. Chronic constipation. Patients may have chronic constipation. They may have growth retardation, multiple fecal masses on abdominal examination, explosive diarrhea, dehydration, shock. History includes failure to pass meconium, painless abdominal distension and constipation. Physical examinations shows distended abdomen with multiple fecal masses on abdominal examination. On DRE characteristically there is anal sphincter is hypertonic. Rectum is typically empty. Hard fecal mass. Radiology. 1. Plain X-rays of the abdomen, erect and supine. 2. Contrast enema. Contrast enema shows narrow distal segment, funnel-shaped dilatation at level of transition zone with marked dilatation of the proximal colon. 24 hours delayed films is important in diagnosis. It shows porine being with barium throughout the colon, as opposed to the child with psychogenic stool holding in whom the barium generally collects in the distal rectosigmoid. Rectal biopsy. Rectal biopsy is the definitive diagnostic test. It demonstrates absence of ganglion cells, nerve hypertrophy and stains indicating increased acetylcholinesterase activity. Treatment includes decompression, introduce a rectal tube and irrigation, colostomy. Definitive procedures. Closing of the stoma. There are many surgical options for pull-through operation, all aiming at resection of a ganglionic segment and then anastomosing the two normal ganglionic ends. They give excellent result in 90%. Some post-operative complications are 1. Anastomotic leak. 2. Stricture. 3. Retraction of the colon. 4. Fecal incontinence, soiling or encopresis. 5. Persistent constipation. This is the invagination of a part of the intestine into itself. It is the most common abdominal emergency in early childhood. In this lecture, our learning objectives are to cover definition, diagnosis, management. It is the most common cause of intestinal obstruction in infants between 6 and 36 months of age. 60% of children are younger than 1 year old, and 80% are younger than 2. Intussusception is less common before 3 months and after 6 years of age. Most episodes occur in otherwise healthy and well-nourished children with male-to-female ratio of 3 to 2. The intussusceptum, which is a proximal segment of bowel, telescopes into the intussuscipiens, that is a distal segment, dragging the associated mesentery with it. This leads to the development of venous and lymphatic congestion with resulting intestinal edema, which leads to ischemia, perforation, and peritonitis. Approximately 75% of cases are idiopathic because there is no clear disease trigger or pathological lead point, most common in children between 3 and 5 years of age. Clinical manifestations are sudden onset of intermittent, severe, crampy, progressive abdominal pain, accompanied by inconsolable crying and drawing up of the legs toward the abdomen. Between the painful episodes, The child may behave relatively normal and be free of pain. A sausage-shaped abdominal mass may be felt in the right side of the abdomen. The stool may be a mixture of blood and mucus, giving it the appearance of currant jelly. Ultrasonography is the method of choice to detect intussusception. The sensitivity and specificity approach 100% in the hands of an experienced. Ultrasonography is better than fluoroscopy in detecting the pathological lead points, monitor the success of a reduction, without exposing the patient to radiation. The classic ultrasound image is a bullseye or coiled spring lesion representing layers of the intestine within the intestine. In addition, a lack of perfusion in the intussusceptum detected with color duplex imaging may indicate ischemia. Plain radiographs of the abdomen are less sensitive and less specific than ultrasonography for the diagnosis of intussusception, but are often performed as part of the evaluation of patients with abdominal symptoms. Radiographic features include signs of intestinal obstruction, massively distended loops of bowel with absence of colonic gas, stable patients with a high clinical suspicion and/or radiographic evidence of intussusception with no evidence of bowel perforation should be treated with non-operative reduction. Surgical treatment is indicated in acutely ill or perforation or after failure of non-operative reduction. Non-operative reduction is by hydrostatic or pneumatic pressure by enema has high success rates in children with ileocolic intussusception, and is the treatment of the choice for a stable child and radiologic facilities are available. Contraindication are long duration of symptoms and/or suspected bowel perforation. Patients should be stabilized and resuscitated with IVF, and the stomach decompressed with an esophagogastric tube. Because there is a risk of perforation during non-operative reduction, the surgical team should be notified and steps should be taken to ensure that the patient is fit for surgery. Antibiotics administered before attempting non-operative reduction because of the risk of perforation. Photos of non-operative reduction. Thank you.